Good evening. Assalamu alaikum. Okay, my patient, 60 years, female. She's a hypothyroid patient, and she had history of CABG 6 months back. Presented with continuous chest pain with minimum exertion. Actually, uh, after doing CABG, she repeatedly meet the surgeon that her pain, just after 2 months, there is increasing pain. And surgeon was in dilemma what to do. He tried all best with anti-anginal drugs, and also he attempted for ETT. She couldn't do ETT even very early, in 2 minutes, patient couldn't, with the chest pain, couldn't do it. The patient came back to me for doing, because her initial angiogram was done by me and I referred the patient to the surgeon. Echo shows there is wall motion abnormality, and angiogram shows there is left main 70 to 80% stenosis at distal segment, LAD totally occluded from proximal segment, LCX 40 to 50% stenosis at mid and 80 to 90% at distal segment, and RCA totally occluded from mid segment. So, and there three graft was there. Lima to LAD 90 to 95% stenosis at anastomotic site, and venous graft to OM totally occluded from proximal segment, and venous graft to diagonal totally occluded from ostium. So that's the her angiogram, as you can appreciate. So 6 months back she had the CABG, and now she presented with two grafts totally occluded, and one graft is nearly to occlusion, and she is having chest pain continuously with minimum exertion. So it's not a very easy case to deal with, and patient is from a low socioeconomic background. Her only child works in a shop. She did with all he has done with the CABG. So with this, we found patient and we have to do something for her. And this case was done in the CSCR cath lab, one of the new cath lab in Chittagong, as opening case, and we offered her, we will do the case with only the cost of the stand, and everything will be free. Okay. So for settling the Lima to LAG, we use IM catheter, 6 French, and for left main to LCS, we use gel 3.57 French. We have to use Guidezilla, we have to use Fine Cross, we use Xion Blue run through wires, and we use several balloons starting from 2 to 4.58. And we use actually 2 stand. So we use IM catheter, and with the workhorse wire, we cross the lesion with the support of the microcatheter, and we pre-dilate the lesion, and we put a drug-coated drug-eluting stent 2.5 by 15, and we fix the lesion for the Lima to LAG. That's, as you can see, the flow established. Then we think about the native vessel, because all her venous graft is occluded by only 6 months. So we have to now change the native vessel. Native vessel LAG already occluded, and RCA is also occluded totally. So we have option distal left main, there is a significant lesion, and as well as there is a lesion in the LCX, proximal end. And there is, as you can see, there is a very tortuous course of the LCX. We apprehended that there will be very difficult to cross. We took Guidezilla to cross the lesion and to pre-dilate the balloon. We use 2.5, and we use a long stand, 4 into 35, or 0 stand in this case we use. And we came up to the ostium actually. And then we used a pot with the 4.5 into 8 balloon. So as you can see the final result from here. Now. So as always, the native vessel is more durable, we chase the native vessel and we fix the native vessel here. Okay. So graft vessel PCI is technically challenging but rewarding for the patient. As in this case, redo surgery is more difficult and more risky for the patient. For doing challenging cases, we need teamwork, perseverance, and educated heart tools. On that case, we didn't have the IVAS on that time, but later we got it. So if we had the IVAS, we could may show more optimization of the result. So, but in this particular case, we have to go ahead with the patient because this patient doesn't have anything to go ahead. So fixation of native vessel is always preferable for a durable result. So thank you very much for your patient hearing.
Thank you, Dr. Anisul Awal, for your brilliant case. There are several beauty in this case. Number one is lima intervention. Lima intervention is always challenging as lima is very much prone to dissection. Lima is very much prone to spasm. And to work in the lima, it should be very cautiously. And number two, you have also done native vessel that is very much tortuous from LM to LCX, and it looked like calcified, but you have very nicely intervened both the lima as well as native vessel. Congratulations, and this is the work of a master of interventionalist. Thank you.
So, did you do the procedure in the same setting? Same setting? In the same setting, you do? Yes.
So I noticed that you mostly use left Judkins guidance for left system. Yes, you and the other operators, I saw that left Judkins mostly, but I would prefer EBU, extra backup catheter, for complex PCI for sure. We use routinely extra backup catheter for all cases, but at least if you have complex case, better to use extra backup catheter.
So, actually, not only the complex case, in our lab, almost all cases, including the ostial left vein, we use the EBU or XB. Judkin guide is, I think, one or two Judkin guide we have in our cath lab only.
Yeah, but it's important point, and I think we have now five cases presented. All of them were left Judkins. So why is that?
That is a great observation. Yeah.
To me, most of the cases of the left coronary system, we use extra backup, except if there is lesion in the mid left main, that is, if I enter furthermore into the left main, I may dissect, or if there is ostial lesion, only in these two situations I use Judkins. Otherwise, mostly I use extra backup.
Thank you, sir.
But all of them have shown excellent results. Yes. So, excellent.
Thank you. So, Dr.